Welcome to the Society of Refugee Healthcare Providers webinar, Pediatric, Immigrant, and Refugee Nutrition. My name is Sarah Clark, and I'm the Society Coordinator. I'm here today with Dr. Janine Young. And before we start, I have a few notes. Please remember to keep yourself muted for the presentation. You can type your questions into the chat, and at the end of the presentation, we will leave time for questions. And then one announcement, as many of you know, the Society alternates organizing the North American Refugee Health Conference, or NARC, every year with the University of Toronto. So this year, the University of Toronto is holding NARC online in September, and their deadline for abstract submissions has been extended to May 3rd. So we really encourage you to submit your abstracts if you haven't already and to register and attend the conference. And I'll put the link in the chat box in a moment. And then I'm delighted to welcome today Dr. Janine Young. She has a very impressive resume, but in brief, she's a general pediatrician at Denver Health and Hospitals. She's an associate professor at the University of Colorado School of Medicine, Department of General Pediatrics. She's also the medical director of the Denver Health Refugee Clinic, co-medical director of the Human Rights Clinic at Denver Health, and serves as the medical advisor for the State of Colorado Refugee Services Program. She's on the executive committee of the AAP's Council of Immigrant Child and Family Health, and she's also a society board member. So thank you, Dr. Young, for being with us today. Over to you.
Thanks so much, and thanks for having me. Wish we could do this all in person somewhere really nice, but obviously that's not happening. I'm going to talk to you about immigrant and refugee nutrition today. We'll leave the questions for the end. If you guys have questions, just put them in the chat box and we can go through them at the end. I'll leave about 10 minutes for questions. Oop. And let's see if I can get this to play. Okay, following are my disclosures. And so the goal of this talk, I mean, we could spend many talks on nutrition in immigrant and refugees, but what I'm going to do is just review some definitions. So protein, energy, malnutrition, which includes stunting, wasting, underweight, Z-scores and the use of them, marasmus and kwashiorkor, very briefly on that because we hardly see that in the United States. I'm going to present a case of malnutrition and discuss workup and management because that's kind of how I operate. Is I think all of us or a lot of people see clinical cases, and that kind of helps us decide sort of what we want to focus on and issues. I'm also going to discuss global prevalence of malnutrition and the impact on new immigrant and refugee arrivals. And I'm going to talk about trying to understand the interplay between maternal and child nutrition, and briefly review vitamin deficiencies, some signs and symptoms. So let's go through some definitions. So malnutrition, mal in lots of languages means bad nutrition. And this is from World Food Program, a quote, "It's a state in which the physical function of an individual is impaired to the point where they can no longer maintain adequate bodily performance processes such as growth, pregnancy, lactation, physical work, and resisting and recovering from disease," which is key here. And there are three main constituents of malnutrition. So there's, as I said, protein, energy, malnutrition. And then part of that is having deficiency in micronutrients, so undernutrition. And then there's also overnutrition and obesity, which also leads to undernutrition. I'm not going to talk about obesity. I think that's an entire talk unto itself. So what's the classification of malnutrition? As I said, it's protein, energy, malnutrition. So on the left-hand side, it's acute malnutrition, which is wasting. Which can lead to marasmus and kwashiorkor, which is severe protein energy malnutrition. It's usually acute that we're dealing with, but you can also have it overlaid with chronic. So it's chronic on acute or acute on chronic. And then there's also chronic long-term protein energy malnutrition, which ends up in stunting. So what are some of the definitions? So underweight is looking at weight for age, and a Z-score definition of less than -2 would be defined as undernutrition. And then there is wasting, which is weight for height. And I'm going to show you pictures about this because honestly, for me, pictures are much better than doing letters. Sorry, with definitions. So the Z-score for a weight for height of less than -2. And it's usually due to recent severe and acute weight loss, but it also may be due to chronic and prolonged lack of proper nutrition and or severe disease, which also leads to decreased immunity. And then there's a sort of vicious cycle where you get decreased immunity, decreased weight, malabsorption. And it peaks at about age 2. And then there's severe malnutrition, which is stunting and wasting Z-score of less than or equal to -3. And this is actually below. I have a citation Lancet from 2013 of Black et al. It's actually a really good review, so I highly recommend it if you're interested in looking at more information. And then there's stunting, which is height for age, Z-scores of less than -2, and it's indicative of chronic malnutrition affecting height attainment. And it affects infants and children from in utero, which I think is key to think about. It's not just that they're presenting and they get malnourished. It depends on how the health is of the mom up through about 3 years of age. And it's the continuing process of failing to grow. And it's associated with later learning difficulties and also a higher risk of obesity later in life. And I just wanted to point out that when you're measuring a young child, it's important when they're under 2 to do a recumbent measurement and really stretch them out to get an accurate measurement. And then stature is actually getting a standing measurement when you're 2 or older. So I wanted to just quickly transition to a case. And actually, this is someone who I followed over time. I first met this child and her very large family when they arrived in the United States in 2018. And I think what I'd like to do is use this case sort of throughout the talk. And I want you guys to sort of think about it, not only in terms of where this child is from, but also the immigrants that we take care of throughout the United States, which is not only refugees, but immigrants in general. I think one of the things that we're noticing and hearing more about in the news is the fact that we have all these unaccompanied children coming from the Northern Triangle countries of Guatemala, Honduras, and El Salvador. And I would argue that all the things that we're going to do to talk about a refugee arrival, we need to think about when we're seeing other immigrants from other countries. And I have to say, we're starting to see many, many more immigrants from Latin America who have been affected by stunting. In this case, however, LK is a 22-month-old Congolese infant born in a Ugandan refugee camp where the family had been living for 5 years. She was born in a hospital and the mother thinks her birth weight was 3 kilos. So it's important to ask. Unclear how well she really knows that it was 3 kilos, how it was measured, when it was measured, and I'll talk about that in a couple slides. She was mostly breastfed until 2 months ago, and the family had minimal access to milk, eggs, and meat while in the camp. Since her US arrival 2 weeks ago, she's been drinking juice, soda, and eating small amounts 2 times a day. So she's mostly on a liquid diet. The mother and father are both short and very thin, and she has a 5-word vocabulary. So from this story, parents are small, probably stunted. They've been fleeing in, also in having poor nutrition status for not sure how long. And this child also has delayed vocabulary, delayed development. So this is a classic picture. I kind of smile because I think a lot of us, we've worked in other countries. I love seeing these babies measured and weighed like this, but it's not the most accurate. Also, I'll show some slides coming up on sort of data on birth weight and when that is measured. And in many countries, birth weight is not measured, or it's inaccurate, or it's not done on the day of birth. And we all know that that can affect, you drop up to 10% of birth weight after birth and within the 2 weeks regain. So I think that it's unfortunately quite inaccurate and not that helpful. And then this is just a slide of all of us sort of notoriously, this kid's kind of bending over. How are we going to get an accurate height measurement? And so it's as accurate as the child who's squirming and the tool. And so I think, anywhere we are, it's going to be affected by how it's done. So getting back to this child, this is a WHO growth chart, and it's recommended to use WHO growth charts in children 2 and under. And the reason is, historically we're using Center for Disease Control growth charts in infants. And the data is that, they were collected on US born population only in the 1970s, not standardized for other populations, not validated in other populations. And so WHO, albeit still needs, more information and it's being worked on, has much better data points for growth charts, and it's more generalizable to multiple populations because they did data collection in multiple populations. So what you can see here is this is a weight for age growth chart. And on the far left-hand side, you can see a little asterisk with the 3 kilo birth weight, questionable, okay? I always ask, we always plot it because it's better than nothing, and it gives you maybe a gestalt of perhaps where this child started. We're at the mercy of the parents remembering. We're at the mercy of all the other things that I talked to you about. But perhaps she was AGA when she was born. However, what we can see if on the far right-hand side is her weight for age Z-score is negative 2.76. Okay, so she is definitely underweight. And you can see over time that as she is here in the United States, slowly starts to gain weight. That one data point to the left that's on the growth chart at the 15th percentile was taken by IOM overseas before arrival. And again, we're at the mercy of lots of things. And I think that was a completely inaccurate measurement. This is a length for age, and this is showing that she's stunted. Okay, so her Z-score, where the arrow is negative 2.79. And so she definitely has stunting, which is chronic malnutrition. Again, the data point on the growth chart to the left was taken by IOM overseas. And again, she can't shrink. And so I think it was inaccurate, okay? But what you can see is actually as she is in the United States, she starts to gain in height. And then here's her weight for length, which shows actually that it's normal because obviously she's very underweight and her height is very low and her Z-score is -1. So what do we know from this? LK is underweight with moderate protein, energy, malnutrition, and she's stunted. So now the next questions are, when did her malnutrition start? Did it start in utero? Did it start with a mom when she was growing up because she had inadequate access to food and then made a baby that was tiny? Or was it postnatal, or was it both? Does she need a further workup? And then what has caused her short stature? So we said it's stunting, but if she was US born, would her short stature be this, would we think stunting? Probably not. So when do you start going down the rabbit hole of doing growth hormone deficiency? Does she have Turner syndrome or other causes of short stature? And how the heck am I supposed to get a mid-parental height on the parents? The parents, I can get a mid-parental height, but can we interpret it? Probably not, because they're also stunted. So we're in a very different setting when we're seeing immigrants in general, whether they're from Guatemala or they're from Congo. And the other question is how do we treat her? Okay, so let's take a step back. So we examine her because that's what we're going to do, right? So you do a full head to toe exam. You assume that she's never been seen by anyone. And so her heart rate's normal, her respiratory rate's normal. And then you're going to be thinking, why is she so underweight? Why is she stunted? Is it just because she doesn't have adequate nutrition chronically over time? Or is it also because something else is going on? Are we missing a kid with an undiagnosed congenital heart anomaly? Are we missing a kid with chronic renal disease who's just having hypermetabolic use of nutrients? Are we missing something else? And does she have signs and symptoms of micronutrient deficiencies? So I'm going to go through this, and then I'm going to show you some pictures. Okay. So she's very small when you see her. She's not in any distress, but she's not looking at you and she's not talking. She has moist mucous membrane, so she's not acutely dehydrated. She doesn't have glossitis, which is associated with micronutrient deficiencies. Her oropharynx is clear. She's got no cavities. Cavities, pain can cause chronic poor nutrition, which would seem like an easy thing to diagnose and treat, but not so in many countries because no access to dentists. So nice, easy thing to fix here. She's got no thyromegaly. She's got no cervical lymphadenopathy, and you're looking for all lymph nodes to see if she's got some kind of, chronic disease, general inflammation. So you look for axillary lymph nodes, groin lymph nodes, nothing. She's got no conjunctival pallor. She doesn't have a murmur associated with anemia. She's not tachycardic. Her lungs are clear. She doesn't have a big liver or spleen. So we're like, okay, no chronic disease. I'm not seeing rashes associated with micronutrient deficiencies or pallor in general. Neuro exams normal, and her external genitals are normal. So she's actually looks pretty good. Let's say she didn't look so pretty good. So this is a picture, this is probably the best picture I've found of atrophic villi and glossitis. On the left-hand side, on the right-hand side is a normal tongue. And so one of the first places you can see signs and symptoms of micronutrient deficiency is the mouth, both perioral and intraoral. And this is either B12 deficiency or iron deficiency anemia. She doesn't have it. Great. This is angular cheilitis of zinc deficiency. So you see in the commissures on both sides, you see this the dry skin, perioral, a kid who's chronically breastfed, not getting really much nutrition in the way of food, zinc deficient. So they can present this way. This is the most dramatic slide I've ever seen of anyone with conjunctival pallor. I've never seen such white conjunctiva, but this is a sign of iron deficiency anemia. Man, if you saw that, it would be pretty obvious. I have never seen anything that bad. And then this is a child, and these are more subtle. This is a kid who's got widened wrists, not so obvious. But it has to do with the dysfunctional way that bone is placed when there's significant vitamin D deficiency. So we're looking for all these things in this kid and any kid who shows up. Okay. Oops. Let me see if I can get through that. Oh, heavens. So what happens with a kid like this is they have, with vitamin D deficiency, rickets, yes. So what happens is there's dysfunctional movement or placement of bone. And so, so you get this widening. I would like to advance my slides and I can't. And everything is frozen. Ah, what'd you do? Okay, whatever. Okay, thanks. Sorry, guys. Okay, anyway, so this, and can you take my lovely dogs out of here too? Thanks. Okay. And shut my door. This is so much fun, you guys. Anyway, this is an X-ray of the wrist, and it's just showing this metaphyseal flaring. And then this is also a child with bowing of their legs, and this is also associated with vitamin D deficiency rickets. And I mean, this is the most obvious that we see, but I have to say that a lot of kids that I see don't have this. It has to do when they're growing early on, they have softer bones, and when they stand, then basically everything splays out like this. And then another thing that we look for is goiter. In children. I've seen this many, many times, and this child did not have it. And most commonly, actually, has to do with iodine deficiency. Okay, so back to getting back on track here. So this is a screenshot of the CDC domestic refugee screening guidelines. And you can use this and the link is at the bottom, really to kind of guide you through sort of approach. There's a section on nutrition and growth that actually is currently being updated. Many of the sections have already been updated. I wouldn't use this tool while you're sitting seeing a patient, however. But what you can use is CareRef. CareRef is in real time updated with CDC domestic refugee screening guidelines. And so what you can do is put in, I'm just giving you screenshots here. This is the state. The refugee departure country was Uganda in our case. Her birth country was Congo, her date of birth, and then you click recommendations. And this is a screenshot of some of the things that you can pull up quickly. And so often actually you can use this in office while you're seeing a patient. So if you wanted to get more of a detailed nutrition history or get clues as to what to look for on a physical exam, you can click in any of these areas. The other piece of this is the lab testing. What you can see here is that you can get the list of all the labs that are recommended for an immigrant or a refugee who's new to country, and it's actually quick and easy to use, and it kind of links back to the CDC domestic refugee screening guidelines. So based on that, you can decide what labs to do on a kid like this. So one of the things there's a standard laboratory panel that is sent on newly arriving refugees. But I would argue that the same labs I would send for other immigrants, particularly kids that we're seeing unaccompanied children from the Northern Triangle countries, other immigrants who are coming in, adult immigrants who are held in our awful immigration detention centers. In this case, because this child was a refugee, she did receive presumptive albendazole treatment overseas for soil-transmitted helminth infections and artemether-lumefantrine for P. falciparum malaria prophylaxis. She did not receive ivermectin because of concerns that she had lived in Congo, which is contraindicated until you get your strongyloides back. Bottom line is if this was a kid who was not a refugee, none of this would have happened. So we get a CBC and diff on her, and that's normal. We're looking for anemia. We're looking for eosinophilia. And shockingly, even though she is stunted, she doesn't have any iron deficiency anemia. We look for lead, and that's 0. Interestingly, her TSH is mildly elevated. Normal range is about 6 or under, and her free T4 is normal. So the question is why is that? One of the reasons is that she can be iodine deficient and therefore start ramping up her TSH to try to get more T4 made because she's not getting enough iodine. Her comprehensive metabolic panel is normal, including a CALS, FOS, and ALK-FOS. And we look at CALS, FOS, and ALK-FOS specifically to look for rickets and metabolic signs of rickets and changes. Her quantiferon is negative. And that's sort of an interesting thing because she is very underweight and stunted. She could be anergic and her quantiferon could be false negative. And so the issue here is thinking about the need probably to test her again for tuberculosis once we get her nutrition scores better and get her back on a growth chart. The other things to look for are infections, chronic infections that can cause stunting, but also the fact that she could have vertically transmitted silent infections. So hepatitis B is negative, HIV is negative, strongyloides and schistosoma are negative, syphilis for vertical transmission is negative, hep C. And in young children, some experts argue that they should have Giardia stool antigens done on children somewhere around 5 and under. Not specifically only if they have diarrhea, but a kid who's got failure to thrive, who's young, 22 months, is not going to say, ow, my abdomen hurts. I'm not hungry because my stomach hurts. And Giardia can cause anorexia, failure to thrive, cramping, and not just diarrhea. And in her case, it was negative as well. Interestingly also, her vitamin D level is not that low. We often see immigrant children coming over, particularly in moms who are veiled, who then make vitamin D deficient babies. I have undetectable levels in some children. And so like I said, her level's not that low. She didn't have any signs of rickets. So what do we do with this case? The family received extensive nutrition counseling over many visits, was referred to WIC, and was given high calorie milk at 30 kcals per ounce. Whole milk is 20 kcals per ounce. And she's prescribed a chewable tablet multivitamin, which includes iron. We don't do gummies just because they don't have iron in them. The recommendation through CDC is children 0 through 6 should all be prescribed a multivitamin at arrival, and anyone else who's at risk. So if they're older kids who are at risk, they should get multivitamins as well. And frankly, what we do in our practice is all women who are of childbearing age, whether they're pregnant or not, are put on a prenatal vitamin because we're presuming most of them are micronutrient deficient. And from my standpoint as a pediatrician, if I have a micronutrient deficient mom, she's going to make a micronutrient deficient baby. They were also told to get iodized salt. We showed them a picture and told them to salt food because we presumed that she was mildly iodine deficient. 6 weeks later, we saw her again. Her TSH was normal at 1. And we also linked her to speech therapy, and she was followed over time. Also, given that she was on a liquid diet, really had some oromotor dysfunction from not eating very much food, being breastfed until she was 20 months. We referred her to a growth and parenting clinic at Children's Hospital Colorado, where they have the luxury of time and can spend an hour per visit with a nutritionist working with the family, having them eat there, which I can't do in my clinic on multiple visits for 20 minutes for follow-ups. So I think that that's also key around education. So this is her growth chart after we have seen her for many, many visits. You can see all those data points, her followed at the Growth and Parenting Clinic and by us. And her weight is actually now approaching a reasonable level. And here's her height. She's on the growth chart. So if you recall, she was way, way low. She was stunted. So when I see patients who are really short, and I can't get good data points on the parents because they're stunted as well, we presume that most of them, based on their histories that you get, are stunted from inadequate nutrition. However, if they don't start acting like they're gaining and getting more appropriate height attainment with adequate nutrition, then you start having to play the game of what you're missing, and if you're missing some other things that we sometimes see in the United States, like growth hormone deficiency, Turner's syndrome, et cetera. And then the one other thing I wanted to talk to you about is in her case, there's the whole thrifty gene hypothesis, which is the idea of, chronic multi-generational undernutrition and starving. And this question and theory of leading to evolutionary selection of genes that do well in times of hunger, but don't do well in times of plenty. And so what happens is stunted children are known to be at risk for later obesity, hypertension, and diabetes. And the theory is that their genes just don't do well processing all that extra salt, processed fat, and sugars. And so over time, this child, we're going to have to follow and make sure she doesn't go to the other extreme. I'm going to segue into data internationally. This is a screenshot from yesterday, actually, from UNICEF on their section on nutrition and the impacts that we don't know yet of COVID-19 and child nutrition. All the slides that I'm going to show you in a minute do not have information on the impacts of COVID-19. And I'm really concerned about it. I think we all are. I think we're going to be going backwards in time, unfortunately. So this is a slide looking at stunting, wasting, and overweight over time in 2000 and 2020. And on the left-hand side is the prevalence of children under 5 that are affected. And so the far left, you see 2000 and 2020, but this is not including COVID data. And part of this has to do with access of nutritionists to areas where they can't measure kids right now. They're not in school. They don't have access to food programs through schools. So everyone is quite worried as to where we're going to be. Right-hand side is numbers, absolute numbers affected. Wasting in 2020, you can see on the right, so less wasting than just chronic stunting and malnutrition. And then obesity is the blue lines. This is a screenshot from a JAMA article from 2016 looking at mortality in kids and adolescents from 1990 to 2013. The top is developed countries, the bottom is developing countries. And I'd like to highlight the 1 to 4-year-old with the arrow that I nicely put in there. Protein, energy, malnutrition is a huge issue in developing countries, what we're talking about. And it's this interplay between malnutrition and infection, because you can see all the way on that lower row is infection, 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 intestinal infectious diseases, malaria, lower respiratory infections, diarrhea, and this chronic vicious cycle. On the upper, you can see that in 1 to 4-year-olds, you don't see anything about infection or malnutrition. It's accidents. And I'm having problems with my slides again. Oh, there we go. Okay, phew. And then this is also from this article, is looking at death rates by age from WHO, 1990 to 2013. Africa, subcontinent is highest death rates, Southeast Asia next, East Mediterranean, Western Pacific, Americas, and then European all the way down, just to give you an idea. And then this slide is from an American Journal of Public Health study from 1993, and it's really just showing deaths in children less than 5 and cause. And again, the interplay between malnutrition and infection. Over 50% of children are malnourished, and that's what's causing their mortality. But on top of that is all of the measles, malaria, diarrhea, lower respiratory tract infections. And I think this gets at this framework of looking at the relationship between malnutrition, infection, and poverty. You start with poverty, there's food insecurity, you're undernourished. Therefore you're at increased risk of infections, you decrease your immunity, you get your infections, you decrease your muscle mass, and then you decrease absorption, and it's this vicious cycle. Briefly, I just want to bring up marasmus and kwashiorkor. And this is a type of acute malnutrition usually, but can be acute on chronic. You see in the picture on the right, it's this very skinny child with very skinny limbs. You can see the skin folds, you can see his rib cage. He can have a triangular facies. It's associated with rectal prolapse. And it's in the first year of life associated with contaminated bottle feedings. And it's really a disease of young children. Young children grow really quickly. They need many nutrients, vast quantities, support their rapid growth. And if you don't have it, you don't have it. We don't see marasmus and kwashiorkor, thank goodness, very much in the United States. And I have to say that IOM, when they're screening refugees overseas, are not going to send a kid with acute malnutrition with marasmus or kwashiorkor because of the associations of significant morbidity and mortality. And also the fact that I think they are much more well-versed in identifying and managing it than most pediatricians and other clinicians in the United States. Kwashiorkor, the origin of the word is from Ghana. It's the disease of the deposed child, or red child because of the changes, skin changes and hair changes and depigmentation. And it's associated with severe immune deficiency and early death. And clinical signs are edema, changes to hair and skin, anemia, hepatomegaly, and lethargy. These are a picture on the left is marasmus, and on the right is kwashiorkor. And no one really knows why one child will get one and one won't, and the risks. And this is a kid with depigmented hair because of protein energy malnutrition, thus red child. Segueing into global hunger index scores, and this is from 2000, 2006, 12, and 20. And global hunger index scores take 4 factors into account. It looks at under 5 mortality rate, prevalence of wasting and stunting of children, and proportion of undernourished. And you can see again that Africa has the highest global hunger index scores. But my handy arrow looking at Latin America and Caribbean, there is an uptick. And it's the theory is, or the feeling is it's the beginning of COVID. And so we will be getting more data on this. And I suspect, again, that we're going to be going back in time, unfortunately. I also wanted to point out global hunger index scores by country from 2000 to 2020. And my handy blue arrows. Really, it's not just Africa and Southeast Asia anymore. We have Venezuela, which has the highest increase in hunger. You can see that on the right-hand side, and has serious levels of issues with hunger. Guatemala also, and Honduras and El Salvador are my other lines. And I'm pointing this out because even though I run a refugee clinic, I also see unaccompanied children in our regular practice. I see mother-child pairs that are coming in, and there's over 34,000 children in influx shelters in border states currently that are going to be coming throughout the United States. And so anyone on this call right now who's working in the United States is going to see these children, whether or not you run a refugee clinic or not. And so the same discussion that we're having about this kid from Congo applies to these children. And then this is part of a graph of child stunting rates within countries from 2015 to 2019, and from data pulled from UNICEF, WHO, and World Bank. And again, I'm pointing out Guatemala, that arrow. And the longer the black line, the larger the disparities there are within country, meaning that they're very wealthy and very poor. And so these are the top countries that have a significant differential between stunting rates from lowest region to highest region. Those numbers on the left-hand side in parentheses is just indicating how many regions of the countries they looked at to get this information. More maps. I hope you like maps. Low birth weight prevalence from 2015. This is the most recent data. Low birth weight infants, there's increased mortality in the first month. There's higher risks for stunting, lower IQ, and higher risks for obesity and diabetes ongoing. I think, again, my focus right now, because everything has been focused on Africa, Southeast Asia, is looking at Central America. There are many low birth weight infants in Central America. We are starting to see more and more of them. And these are the risks that they have. Again, the data is based on how we're weighing kids, but it is what it is. This is a slide that doesn't look fabulous, and I'm not sure why it turned out this way, and I'm having technical difficulties today, which is a bummer. But on the left-hand side shows the percentage of infants weighing less than 2,500 grams by region. And then this is what I was getting at before, which is the percentage of infants not weighed at birth. And so again, you're at the mercy of whatever data is collected and whatever the parents remember of the data. And this is a percent of children less than 5 affected by wasting. So again, wasting is acute malnutrition. And so you're not seeing acute malnutrition so much in Central America, although that may be changing, and we're seeing it mostly in Africa, Southeast Asia. And this is the percent of children less than 5 affected by stunting, again pointing to areas in Latin America where there is chronic malnutrition, and also then the rest of the world. And finally, this is a slide that's looking at the percent of babies who are breastfed through 5 months of life. And I don't know why they used pink, but pink is bad. So less than that dark pink, less than 20% of infants are being breastfed through 5 months of life, and obviously older are not getting it. And so many parts of the world are not breastfeeding, which is a big problem. I'm going to segue into talking about the effects of maternal health on infant health and child health. This is a very old slide actually from Papua New Guinea, and it shows a very emaciated mother who's got maternal depletion syndrome. And she has that for many reasons, but one of the main reasons is she's got 5 kids and she's had kids back to back and has not been able to replete herself of all micronutrients. So she is wasted. Her infant is wasted. And then her 2 younger children standing next to her have distended bellies and skinny legs. They don't have kwashiorkor. They have environmental enteropathy. And this slide is showing the interplay between maternal and child health and vice versa. You have a child who's depleted, you have a mom's depleted, and vice versa. Environmental enteropathy is when you have chronic repeated intestinal parasitic infections like Giardia, Ascaris, hookworm, et cetera, which leads to chronic inflammation, blunted villi, malabsorption, chronic diarrhea, anemia, poor weight gain, and abdominal distension. This article is quite good, The Impoverished Gut, a Triple Burden of Diarrhea, Stunting, and Chronic Disease, and it kind of goes through this whole thing. But again, like I was saying, it's this interplay between malnutrition, poverty, and infection, and they all go together. But I wanted to talk about that mom and the effects of maternal malnutrition on the fetus and the infant, because the kid that I presented to you in the beginning is a product of her parents and her mother's health. And even though I'm a pediatrician, I need to make sure that the mother is getting adequate nutrition as well, because when she gets pregnant again, if she is malnourished and has poor iron intake, et cetera, she's going to make another baby that is the same. What we know about short women who are stunted are they're at greater risk for obstetric complications because of their smaller pelvic size. And then there's a strong association between their height and their birth weight. So you make SGA, IUGR babies, vicious cycle, and it's independent of maternal body mass. And there's the intergenerational effect. Small babies make small adults, make small pelvic size, et cetera, et cetera. So how do you stop this? And so again, thinking about both the mom of my patient who I presented to you and that photo, is I would assume that this mom has low vitamin D level. She's had multiple pregnancies back to back. She's breastfeeding, she's dark skinned, she's malnourished. And in the women who I take care of who are wearing hijabs or their children, they have no sun exposure. They are all vitamin D deficient. I've had kids with 0 levels of vitamin D. She probably has low iron. She could have lead elevation. She might have iodine deficiency because her kid does, and B12 deficiency because she doesn't have access to meat, milk, eggs, okay? So mom is like this, she makes a baby, baby is like this. So maternal vitamin D deficiency is associated with low birth weight. It's linked to increased risk of preeclampsia, and they often also have a small pelvic outlet and flat pelvis. Does this sound familiar? It increases the chance of C-sections, increased morbidity and mortality of the fetus and the mom. So what are the risk factors for vitamin D deficiency? I showed you the pictures before. So what we see in kids are they're stunted, they're wasted, they're undernourished. They have a history of being IUGR, SGA, or preemie. If you're preemie, you don't cook long enough, therefore you don't transfer all of those great nutrients that maybe mom has to the baby. The mom is vitamin D deficient, so she's veiled, dark skinned, malnourished. The infant is veiled, dark skinned, or malnourished, or the kid is breastfed only. So I'm actually really surprised that that child I presented to you was not more vitamin D deficient. What we see in the child, besides what we saw in the pictures, is irritability, delayed walking, leg pain, fractures, poor weight gain, bowing. Bowing's the obvious one. I wish that they would present that way in all cases. Delayed fontanelle closure, frontal bossing, delayed tooth eruption, and widened wrists. In iodine deficiency disorders, which we think this child probably had a small amount of, in utero, if mom is iodine deficient, she has an increased risk of spontaneous abortion and stillbirth, preemies, perinatal mortality, cretinism, which is the most preventable common cause of brain damage in the world because of iodine deficiency. And in childhood, you can see goiter, failure to thrive, dry skin, and then subtle decreases in IQ and neurocognitive performance, hypothyroidism, and macroglossia. So adequately iodized salt can protect children from brain damage. And only 88%, only to me, because to me, I can't imagine what an easy thing to fix. 88% of the world's households use iodized salt. And it's especially damaging when you have deficiency in early pregnancy because you're building a baby that needs neurocognitive development and also early childhood. Mild deficiency can cause significant loss of learning abilities. And in 2013, more than 35 million newborns were unprotected. This is a current slide of most recent data of where in the world there is still iodine deficiency, including Haiti, and then parts of Africa and parts of Southeast Asia. So it's something to think about, honestly. And if you're seeing a malnourished kid, or frankly, if you're seeing a woman of childbearing age who's coming as a refugee or an immigrant from some of these areas, I would get a TSH, because if she gets pregnant, she's going to make an iodine deficient baby, and neurocognitive hits in utero are as bad as they can come. The other things to think about in moms and babies is iron deficiency and iron deficiency anemia. In utero, it can cause prematurity, low birth weight, and perinatal mortality. And in childhood, we all know subtle delays in neurocognitive and motor skills. There's an increased risk of associated lead toxicity, increased symptomatic iodine deficiency. You can get, as I showed you in the pictures, angular cheilitis and taste bud atrophy, pica, and fatigue. So mom, baby, baby, mom. So when I see a baby who has severe iron deficiency, I also think the mom might be. And it's the most common micronutrient deficiency in the developing world in over 2 billion people. And so again, maternal insufficient iron stores, the iron accumulation goes to baby during the 3rd trimester. You make an iron deficient infant. You know, the other thing to think about is there's increased iron need during periods of growth. So in early childhood, adolescence, and pregnancy. And then malabsorption can cause problems with iron absorption, low-grade blood loss from parasitic infections. So we see this a lot. So the bottom line in all this is there's a clear interplay between a mother's nutritional status, both prenatally, perinatally, and postnatally in her children. So it's really important to address nutrition of the entire family when evaluating any child for malnutrition. Okay, cute baby pictures. In conclusion, malnutrition is a global health issue that has been significantly exacerbated by COVID-19. Immigrants and refugees will present with malnutrition, which is often multi-generational, and is important to be able to diagnose, work up, and treat it both short and long term. And it is essential to address malnutrition in the family and assure treatment of women, children, and the rest of the family as well. Thank you for your patience with my technical difficulties and my dogs, and I appreciate your attention.
Thank you, Dr. Young, for that wonderful presentation. We've had a few questions come in the chat, so we'll start the Q&A now. Dr. Young, the first question is, how do you calculate the protein energy malnutrition? Is it based on Z-score? The child in the case was moderate, wondering how you get to that classification.
Those are great questions. So Z-scores, you know, are statistical modeling, and I'm not a statistician, that allows you to sort of get a gestalt overview of comparing to general populations malnutrition. And so it all depends on the Z-score. So if you have a Z-score of -2 or more, and what's really lovely now with our electronic medical record is it automatically calculates it for us. So I don't have to do anything. So basically I hover over, I have Epic, not to promote any EMR, but if you hover over any data point on a growth chart, it'll actually give you the Z-score. And so if you look at the Z-score and it's -2 or more, that would be qualified as moderate malnutrition.
Thank you.
Mhm.
The next question is, this person is going to go work on the border with unaccompanied minors in a few weeks, and they're wondering what should they look for when they're working with these.
Wow. I'm really glad you're going. We're all like on this wait list to go, and it's pretty, I would say, complex in terms of how they're getting people down there. So I actually congratulate you on being able to coordinate going. Um, it's anyone's guess, honestly. What I'm at least hearing is, a lot of acute issues. Most of the kids you're going to see are going to be from Latin America. Although there are some kids coming and making the trek. We get stories of people somehow making it to Brazil or Chile and then walking or driving and hitchhiking all the way up to the Mexican border. Um, I think I think for the most part, it's going to be chronic stunting. There might be some acutely dehydrated kids, acute malnutrition. I haven't heard that there's been much, but then there's all the unfortunately COVID infectious diseases. So what I think is probably happening is a lot of very quick and active triage because Customs and Border Patrol and ICE don't have any pediatric trained folks to triage, which is a chronic, awful issue. And so part of the problem is they don't know norms for vital signs in children. And so you could have a very tachycardic, tachypnic kid who's has hypotension, who's hypovolemic, that could be missed. So I think it's going to be rapid assessment from an emergency room kind of approach of triaging acutely ill children if you're going to be right at the border, and deciding who needs IV fluid, who needs to go to somewhere where there's actually more support and care for more complicated children, um, frankly, with pediatric trained people and the support staff to do it. That's my guess as to what you're going to be dealing with, and also just injuries, on the trek. So a lot of acute triage. I think the issue is when these kids then go to ORR shelters. There are over 125 ORR shelters across the country. So they're stabilized, and then they're supposed to be relinquished to ORR custody. They're flown to an ORR shelter, quarantined, which is also, I think, from a mental health standpoint, very traumatic, from a toxic stress standpoint. And then I think when they're released into the community, what we're more dealing with is some of the chronic diseases and chronic infections and chronic stunting, and working those things up and thinking about vertically transmitted diseases that weren't picked up overseas, and all of the stuff, chronic diseases that aren't being picked up. So I think from the acute standpoint, it's what I said, and from the chronic, I think that's what we're really going to be seeing, unfortunately, a lot of.
The next question is, do you provide children's vitamins, as Medicaid does not cover that in our state and we can't get most parents to purchase them?
Yeah, I think the do no harm discussion is huge. So I've seen people like give lists of things for the parents to buy. That's doing financial harm. And so I think uh, if you can, we've had discussions about this a lot, is, what are we obligated to do? And is, from a refugee screening standpoint, the recommendation is to provide multivitamins, right? So our discussion was, well, if it's recommended, then we need to cover it. And so we personally, at my hospital system, arranged through our foundation at Denver Health to actually use funds to cover those costs. And I think many sites in the country are using these kinds of innovative I don't even know if that's the right word, but approaches to trying to cover things that aren't covered. In our state, Medicaid doesn't pay for, open Medicaid doesn't pay for over-the-counter medications, including iron and vitamin D. So if I have a kid who has a hemoglobin of 5 and I want to provide liquid iron, the parents would have to pay for it. And so what we do, at least with our refugee arrivals, is we have our foundation cover it, because can you imagine you have a family of 8 and they all are iron deficient and they're all vitamin D deficient, and you prescribe all these medications and they're not covered. So I don't have a great solution. I've also heard of other people working with nonprofits that donate. Do I think it's right? No, but that's where we are.
Mm-hmm. Are there different links for measuring malnutrition and stunting for different regions?
So WHO growth charts are the best, but they're not perfect. And they don't have subpopulation data. So in other words, I don't have a WHO growth chart for Somali kids. And arguably, I think we probably should. I don't work for WHO, so I don't know if anyone else is on the line who could comment on where there are in development of these things. My guess is right now, I'll use the COVID excuse, is that none of that is happening. But no, I mean, the best we have is WHO, and that's it. And the other piece of it is using parents and other kids in the family to get a sense. But again, if they all are chronically malnourished, it's really hard. And it gets even harder, frankly, and I didn't bring this up in the talk, when you have kids where you don't know their dates of birth and they're stunted. Because then it's really hard to figure out their age.
Mm-hmm. Mm-hmm. Well, thank you again, Dr. Young, for this presentation. That's all we have time for today. And I just want to remind everyone, we will make the recording available to you afterwards. And just another plug to please submit your abstracts to the North American Refugee Health Conference if you haven't done so already. Thank you, everyone. Have a good day.
Bye.
Bye.